The next topic we're going to cover is the topic of stiffness, which is a major problem in total knee replacement and something which is now being looked into both in the basic science aspects as well as the clinical aspects in terms of prevention and treatment. So let's talk a little bit about stiffness. The first question here, and this is something which is very basic and an important concept to understand, is that the range of motion, the most important aspect which resultantly leads to improved motion in the knee is listed. These are possible options listed here, and the correct option is always that the principal predictive factor of postoperative range of motion is the preoperative range of motion. Now, interestingly, only about a third of the respondents were correct in terms of that particular answer, but that's important to know. A knee that is mobile prior to surgery oftentimes has less problems with stiffness than a knee that is stiff when one does the replacement. How do we define stiffness? Well, there's a lot of ways that it's defined in the literature, but for most of us, in terms of flexion contracture, anything more than 10 degrees is of significance, and flexion that is less than 90 degrees is generally accepted as stiffness in the knee. Incidence is very variable. And again, anywhere between 1.3 and 12% of knees. And you can see in this paper, patients who had a prevalence of stiffness about 1.3%, revision surgery may be necessary after you've exhausted every other option and stiffness continues to be a problem. Revision surgery is an option for treatment, although not the first option, certainly. So what are the risk factors in terms of resultant stiffness after knee replacement surgery? Well, as we mentioned, the most important was poor range of motion to begin with. Patients who've had previous surgery, as a rule, and have fibrosis in the infrapatellar area with a patella baja, they can have compromised flexion of the knee. Increased comorbidities, which promotes stiffness in soft tissues, can certainly lead to limited motion. And patients who cannot cooperate with rehabilitative programs oftentimes will have limited motion, particularly if you have problems controlling their pain. And then this can certainly be a major risk problem in terms of getting good motion afterwards. Of course, the area of RSD is an issue as well, and another example of the most extreme problem in terms of maintaining adequate pain control, and oftentimes these patients end up with significant stiffness and are major problems in terms of clinical care. So in terms of technical factors, again, which can produce stiffness in the knee aside from the soft tissue problems, overstuffing of the patellofemoral joint, where a small amount of patella bone is resected and a large implant is used, or anteriorization of the femoral component, so the patellofemoral joint is very, very tight, will limit motion. Malrotation also can play a role in terms of asymmetric stiffness in the medial and lateral side of the knee, which can compromise flexion. Tight flexion and extension gaps leading either to a flexion contracture or a tight flexion gap so that when you flex the knee, it does not easily flex. In the operating room, I like to flex the knee easily beyond 90 degrees to be sure that my flexion space is not too tight. Elevating the joint line also can produce tightening of the soft tissues and stiffness in the knee. And as a rule, most of us close our knees now in flexion and this may avoid excessive tightening of the extensor mechanism as we close the knee and lead to less soft tissue contracture about the knee. Certainly a tight posterior cruciate ligament, rather than a lax posterior cruciate ligament in the PCL retaining knee. If it's lax, you can have flexion instability. If it's too tight, your motion can be compromised. Postoperative factors, delayed rehabilitation for some reason. Infection, of course, is a significant problem, or bleeding into the knee. HO, anything that, on occasion, if there is excessive hematoma formation in the knee or trauma to the quadriceps extensor mechanism, you can see ossification in the extensor mechanism, and that will compromise flexion of the knee. Hamstring spasm can do it. That's usually dealt with. That usually resolves itself. And the use of a CPM machine is very controversial. Most of us do not use it now. There are a number of studies in the literature, this being one of them, that has documented that, in fact, CPM machines in the long run do not lead to improved range of motion. So, in terms of evaluation of the stiff knee, got to rule out infection. Major potential cause should be ruled out. Radiographs can be helpful, particularly in terms of ossification. I've not found CT scans particularly helpful, but an MRI done well can oftentimes show significant scar about the suprapatellar pouch and about the medial and lateral gutters, and can be helpful in terms of the approach, in terms of leading you toward an arthroscopic procedure with removal of adhesions, or a revision if the extent of the soft tissue fibrosis is global throughout the joint. So here's another question referable to stiffness. And here's a 45-year-old woman undergoes an uncomplicated knee replacement. 9 months later, 9 months, she still has not returned to work because of pain and stiffness. Her range of motion is still not good, 5 to 80 degrees. She has no instability. She can't do stairs. She has problems sitting. She is no longer participating in physical therapy. She has pain on standing. Her radiographs show a well-positioned knee. The workup for infection is negative. What is the next step in terms of management of this patient? Dynamic splinting, if you run through these options, probably not too long down the road, probably will not help in terms of stretching this knee and improving motion. Open release of adhesions is an option. Manipulation under anesthesia at 9 months, probably not a good idea in terms of potential morbidity with that. Revision to a cruciate sacrificing implants, probably not an option at this point. And arthroscopic release of adhesions and manipulation as part of that is the best option in this particular case at 9 months with a persistent stiff knee. And you can see that the answers were sort of varied here. Some 25% of people felt they would still manipulate the knee. I think at 9 months, there is some risk to doing that, so I would not recommend doing that. I think an arthroscopic procedure in this setting oftentimes will improve range of motion, not significantly, maybe 10, 15, 20 degrees, but it's certainly the first option, and if unsuccessful, then a more open procedure is indicated and potential revision. So if we look at the non-operative treatment of stiffness, a knee that is stiff and flexes less than 90 degrees within the first 12 weeks after surgery, and there are some people who manipulate the knee very early and others that manipulate it out to 3 months. A manipulation certainly is indicated. Again, there are potential downsides to manipulation, including fracture if you're too vigorous, or rupture of the extensor mechanism. Myself, on one occasion, with a very, very stiff knee, manipulated it beyond 12 weeks did have a disruption of the extensor mechanism, and in the end led to not a good outcome. The contraindications are greater than 3 months, and I would agree with that. Rarely is the knee, you could go 3 to 4 months, maybe on a rare occasion even out to 6 months, but as a rule, I think the teaching is beyond 3 months manipulation. It has significant risk and probably not indicated. The operative treatment, as we mentioned, arthroscopic lysis of adhesions, got to be quite extensive. You may need 4 portals when you do this so that you can get into all areas of the knee, and then manipulating the knee as you do that procedure to try to improve motion. For persistent late stiffness without resolution or improvements with either manipulation or arthroscopic procedures, then you're looking at an open procedure, and usually at that point revision knee replacement is indicated. And correcting if one of the earlier potential problems leading to stiffness is present, correcting that as part of your revision procedure.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.